Assalamu alaikum warahmatullahi wabarakatuh. Welcome to a new session from Radiology Spotter Cases at first Ramadan Kareem. And this session will be followed by discussion as we used to do this session. And we will start immediately. Okay, let's discuss cases. This first case we can see here in this 4 years old infant. We can see here that there is a focal area of abnormal signal that is seen at the left frontal lobe. This focal area is seen extending from the cortex to the all through the white matter to the ventricular outline. So this area of abnormal signal is very characteristic for the focal cortical dysplasia by this sign, which is called transmantle sign, which is extension of the abnormality from the cortex to the ventricular outline. This is called transmantle sign, and this is one of the pathognomonic features for the focal cortical dysplasia. In these T1 weighted images, we can see the ill definition of the gray-white matter interface at the region of the focal abnormality focal cortical dysplasia. And again, this is one of the characteristic features of the focal cortical dysplasia is the ill definition of the gray-white matter interface. Here the gray-white matter interface is clear, but here we can see that there is an ill definition of the gray-white matter interface, best appreciated at T1 weighted images, and this is again one of the characteristic feature for the focal cortical dysplasia. So this is a left frontal lobe focal cortical dysplasia. Here in the second case, we can see that there is a foreshortening of the ulna. The ulna here is foreshortened. It's the excessive negative ulnar variance, and there is a bowing deformity of the ulna that is come in contact with the proximal portion of the sigmoid notch of the radius. This abnormality is characteristic for which called ulnar impingement syndrome. Ulnar impingement syndrome is characterized by foreshortening of the ulna, bowing of the ulna, and is abnormally contacting the proximal aspect of the radius. This called ulnar impingement syndrome. This is different from ulnar abutment syndrome, which is a positive ulnar variance, and there is an articulation or contact with the lunate and abnormality in the medial aspect of the lunate. This is called ulnar abutment syndrome, while in this case this is called ulnar impingement syndrome. There is a excessive negative ulnar variance. There is an abnormal contacting with the ulna with the proximal radius, and the friction occur at this side. This is called ulnar impingement syndrome. Okay, in this case it is discussed in detail in the last film reading session. It is representing one of the complication occur after craniectomy operation, in which there is the skin flap undergo excessive sunking or collapse. This appearance, which is called sinking skin flap syndrome, or called trephine syndrome, in which there is a sinking of the skin flap after the massive craniectomy, in which there is the etiology underneath is due to the difference in the pressure gradient between the atmosphere and the brain pressure inside the brain itself. This make the flap is bowing inward like this, and this is one of the complications after craniectomy, and it is discussed in detail in the last film reading for if one interested to know more detail about this entity of complication. The case number 4, here we can see that there is a space occupying lesion, bilateral space occupying lesion, one seen at the right anterior frontal lobe, the second seen at the posterior left frontal or frontoparietal region. These lesions are characteristic to be high in T2 and FLAIR images without significant mass effect or significant edema respective to their size. They are considered large region. In spite of this size, there is no significant mass effect, And in the post contrast images, we can see there is an incomplete ring enhancement seen at the post contrast images. All these features are characterized of demyelinating disease or demyelinating lesions. So we consider demyelinating lesion once you see lesions like this with no significant corresponding mass effect, and in the post contrast image there is a incomplete ring of enhancement. Here we can characterize this in T2 weighted images. In this lesion we can see that there is an alternating layer, concentric layer of low and high signal, and this is one of the feature of type of demyelinating disease called palosclerosis, concentric palosclerosis. So this is a case of demyelinating lesions or concentric palosclerosis, and this is a very characteristic. These alternating layers is characteristic for these type of disease. In this case we can see there is a severe attenuation of the body of the medial meniscus and the meniscal flap, or there is a meniscal flap seen underneath the posterior cruciate ligament. Here the posterior cruciate ligament, and we can see here this is the displaced meniscal flap seen underneath the posterior cruciate ligament. So this is characteristic for bucket handle tear. Bucket handle tear usually characterized by attenuation of the meniscus and displacement of the meniscal flap underneath the posterior cruciate ligament. This is called bucket handle tear of the medial meniscus. In this case we can clearly see that there is a widening of the posterior fossa. There is a large cystic lesion occupying the posterior fossa, and there is an elevation of and hypoplasia of the cerebellar vermis seen in this sagittal image, and this is clearly diagnostic of the Dandy Walker malformation by the widening of the posterior fossa, large cyst, and there is a hypoplasia and elevation of the cerebellar vermis. So this is a Dandy Walker malformation in these images, and this is very important. We can see that there is a nodular lesions at the ventricular outline, one here, and there are similar lesions here seen in the body of the lateral ventricle. These lesions are similar to the cortex, so this is a gray matter heterotopia, and this is very important in cases of the Dandy Walker malformation or any cases of posterior fossa abnormality, to see there could be an associated with a supratentorial abnormality. So you should clearly check the supratentorial structures, and if there is an associated congenital anomaly, in this case we can see that this is associated with a gray matter heterotopia. So this is a Dandy Walker malformation associated with a subependymal gray matter heterotopia. This is a classic appearance for the pluming effect of the cavernoma. This is a lesion here in the right frontal lobe. We can see that there is a appearance of the punctate appearance of the or popcorn appearance of the lesions in the T2 weighted images. That is dark signal in T2 and seeing the punctate appearance or popcorn appearance of the lesions. In the gradient weighted images there is a blooming effect of the lesions. So this is a very characteristic for the cavernoma. So this is a right frontal lobe cavernoma. In the post contrast images we can see here that there is a linear enhancement with a brush-like appearance that is draining into one of the ependymal vein. This is characteristic for the developmental venous anomaly that is commonly to be associated with a cavernoma. Here the lesion, this is a cavernoma here, and this is the linear density or linear enhancement and brush-like appearance that is characteristic for the developmental venous anomaly. So this is a right cavernoma, right frontal lobe cavernoma associated with a developmental venous anomaly, or called DVA as an abbreviation. Here in case number 8 we can see that there is lesions that is involving one of the dorsal vertebrae these lesions is associated with some sort of expansion of the vertebrae and extraosseous soft tissue component, prevertebral extraosseous intraspinal soft tissue component that is high in T2 and showing a homogeneous enhancement in the post-contrast images like this. So this lesion is showing one of the characteristic appearance that is showing a linear striations. We can see here this linear striation, which is very characteristic for the vertebral hemangioma. And if we see here in the T1 weighted images, the regions is showing some signal that is high in T1 weighted images, and again this is one of the characteristic for vertebral hemangioma. This is a characterized type of vertebral hemangioma called aggressive vertebral hemangioma. This vertebral hemangioma is usually associated with an extraosseous soft tissue component like this, and involving also the body and also the spinous process or the posterior neural element. Here and here we can see that there is an enlargement and the appearance of the stippled appearance of this stippling appearance is very characteristic for the hemangioma. If it is associated with an extraosseous soft tissue component, it is called aggressive type of hemangioma. So this is a typical example for vertebral aggressive hemangioma. The other differential diagnosis is the Paget disease of the vertebrae due to enlargement and due to this striation or trabeculation. But in the Paget disease, there is no associated with an extraosseous soft tissue component, and the higher signal in T1 also, it is one of the characteristic for vertebral hemangioma rather than Paget. So this is an example for the aggressive hemangioma. This case is very important because many of us can consider this as a malignant lesion or metastatic lesion due to the association of extraosseous components, but this stippling appearance is very characteristic. The linear or the striation, this is also very characteristic, and also the areas of high signal in T1 is very characteristic and make the diagnosis of vertebral hemangioma, aggressive vertebral hemangioma is considered rather than to be an aggressive neoplastic lesions. In this case, case number 9, there is a lower pool in this kidney. There is a partially exophytic, well-defined lesion. This lesion showing an areas of breaking down and heterogeneous enhancement. In these images, we can see that this is MIP images. We can see that there is a abnormal vasculature here. This is called a new angiogenesis that is characterized for the neoplastic nature of the lesions here in the renal cell carcinoma. So this angiogenesis is very, very important. This presence of abnormal urbanization or abnormal vessel enlargement, this is called angiogenesis or new vasculature or new vascularization that is seen in the malignant lesions. So this is especially the renal cell carcinoma, and this is one of the important features for the renal cell carcinoma is the presence of these abnormal vessels. So this is an example for the right renal pool, lower pool renal cell carcinoma. In this case number 10, there is an right frontal hematoma, and there is a diffuse fronto-parieto-occipital subdural hematoma, also acute hematoma. In this angiography, we can see that there is an association with ECOM bilobed saccular aneurysms. This saccular aneurysm is seen arises from the ECOM. So this is an ECOM bilobed saccular aneurysm associated with an intracerebral and subdural acute hematomas. This is a classic and typical example for the ice cream cone lesion that is seen at the left cerebellopontine angle lesions. We can see the intracanalicular extension and the cystic area in the post-contrast images. These all features for the left cerebellopontine angle schwannoma. This is a very characteristic and very classic, the appearance of the ice cream cone with intracanalicular extension, the cystic area of degeneration seen within the lesions after contrast enhancement. This is a very characteristic of the schwannoma, absence of the dural tail. This is with schwannoma rather than 2P meningioma. Okay, in case number 12, we can see there is a midline falcine lesion that is low in T2 and show homogeneous enhancement in the post-contrast images. This is a characteristic for falcine hemangioma, midline falcine meningioma. So this is the low T2 signal. This is one of the characteristics for the meningioma, and also the homogeneous post-contrast enhancement. This is one of the characteristic feature of the meningioma, and sure this is an extra axial dural based because the falx is one of the dural attachment. So this is a dural based extra axial lesion that show low T2 signal and homogeneous post-contrast enhancement. This is called midline falcine meningioma. In this case also there is a typical or another example for a type of the displaced meniscal tear, in which there is a blunting of the body of the medial meniscus. This is the body of the medial meniscus. It is blunted here. It is not pointed, so it is blunted here, and we can see displacement of the meniscal fragment seen in the inferior recess. We can see here this is the meniscal fragment that is displaced here, and this is the body of the medial meniscus. So this is an example for flap tear, in which there is a displacement of the meniscal fragment adjacent to the meniscus, either into the superior recess or into the inferior recess. In this case, the displacement here into the inferior recess. And again, this is one of the characteristic features for flap tear of the body of the medial meniscus. This is 3-month-old patient. He comes with a swelling in the parotid region, and we can see this is a non-contrast and this is a post-contrast images. We can see here that there is an intense homogeneous enhancement in the post-contrast images in the left parotid space region, and we can see this abnormal vessels seen within the lesions. So it is an hypervascular lesion seen in the left parotid. In this age, we should consider the possibility of a parotid hemangioma, which is one of the common location to be occurred is the parotid space. So in this age group and in such location with such intense enhancement lesions, you should consider parotid hemangioma, which is usually the type of parotid hemangioma occur usually infantile type. So this is usually left parotid infantile hemangioma. Here the last case, here we can see this is a patient with a history of trauma. We can see this there is a subarachnoid hemorrhage, scattered subarachnoid, some sort of subdural hemorrhage. But in the MRI images, we can see multiple scattered foci of blooming artifact or hemorrhagic foci that is seen in the subcortical white matter and also in the corpus callosum. This is one of the characteristic location for diffuse axonal injury, especially if after following the trauma, and this revealed the significance of the MRI and higher sensitivity than the CT. These lesions or these hemorrhagic foci are not appreciated in the CT study and revealed in the MRI study better. So this is an example for the diffuse axonal injury, in which there is a multiple hemorrhagic foci involving the cerebral hemispheres and also the corpus callosum. In the setting of the trauma, we should consider the possibility of diffuse axonal injury, of course, after revealing the clinical history of the trauma and severe deterioration in the conscious level. We should consider diffuse axonal injury. I hope these were an interesting cases, and meet you soon, and Ramadan Kareem. Thank you for your attention.